Good afternoon, everyone. We're going to get started now. My name is Catherine Hateman, and it is such a joy to welcome you all here today. Whether you are a longtime supporter of Children's Place or perhaps you're joining us for the first time, welcome. Thanks for coming. Having you here means the world to us. This gathering is a testament to the incredible community that we have. One that believes in the power of community-led change, that believes in equity, and believes in the lasting impact that we're all able to have when we act together. So today we're here to celebrate those strides that we've made in addressing child suffering around the world, as well as to appreciate the courageous work of our community-based practitioners, two of which you'll hear from later today, and to appreciate and say thank you for the generous solidarity from all of you. We're also here to look forward. We know that there are challenges that we still need to overcome. We know that there are children and families around the world who are still experiencing truly heartbreaking, difficult, unjust conditions. And so we're going to keep fighting on behalf of those children and families. And over the next 3 months, we are launching our Place the Hope campaign. And I know many of you have joined us before for that effort, and we sincerely hope that you will do so again. Your support, whether it's through, your time, your outreach, your donations, spreading the word, all of those things really do help to fuel our mission and to help create a world where every child is able to thrive. So thank you for being part of the journey with us. We really could not do this work without you, and we look forward to the hope that we can spread together.
Great. Thanks so much, Catherine, for those opening words. And I see so many familiar faces here, and so good to see friends. And for those of you who don't know me, I'm John Sweeney. I'm Executive Director of Children's Place International. So thank you all for being here today. Whether you're a community partner, a volunteer, a donor, a staff member, you truly are the backbone of everything we do. So I'm just going to start off with what I feel is a really startling statistic, something that is unbelievable, unacceptable, and just all around awful, I guess I could say. And that is that every year around the globe, there are 6 million kids and teens who are dying from diseases, I should say in lower income countries, that are treated back here with a really high probability of success with widely available drugs. It's unbelievable and shocking, but also true. And I can tell you, and I know some of you have certainly had this experience, that there is nothing more tragic, more horrific than to enter a hospital clinic, a children's ward, and to see kids with highly treatable conditions essentially condemned to die for lack of sometimes even as little as a few $100s in medicines. So when Children's Place International was launched 18 years ago, we asked ourselves a couple of questions. One was, what can we do to help change the situation? And the second was, maybe more specifically, how could we have the greatest impact on the greatest number of kids, given our bandwidth and given the absolute enormous need? To start in answering this question, we had a really, really important realization, and that is that there are already highly effective organizations operating in the communities where we were trying to reach. And these are organizations that are led by people from the community or grown up in that community. They know better than we ever could the needs of that community and the solutions in addressing those needs in the community. So that started us on a path of partnership. And we began partnering with these organizations to support kids with illness such as HIV/AIDS, cancers, and sickle cell disease, among others, to not only meet their health needs, but to also support a pathway out of poverty through education and career readiness. Our very first partner is and was Zamdi La Sante, very renowned organization, Partners in Health Haiti. And then we followed into the Dominican Republic and started partnering with Clinica Familia La Romana and Kilimanjaro Christian Medical Centre in Tanzania. And Dr. Majaliwa is here today with us. And then most recently, Moi Teaching and Referral Hospital in Kenya, represented by our honoree today, Dr. Njuguna. These are all truly blue chip organizations who operate national and even transnational regional health centers integrated within their national health systems. And I raise that because what that means is as we have success in partnership, there is the possibility of scaling that success at a national level through integration to the national healthcare systems that these organizations are already part of. And I would just say that as this partnership experience developed for us, it has proven to be highly effective. And so I've been talking conceptually so far, but I want to share just one story of a family that we met in Haiti in 2008. So you can see the photo hopefully here. And so we have Evan and Elmanie here with their mom right in the center between the two of them. And when we first met them, the pictures on the lower left and right are what they looked like when they were in kindergarten and first grade. And I remember actually meeting them and their mom and understanding the situation they found themselves in, which was truly unimaginable. Mom was caring for 6 kids and often did not have enough food for them, and really just did not have access to a lot of resources. And so over the years, with us and Zame Lasante, they received critical supports for medicine and nutrition and education, among other resources. And so Elmanie and Evans grew up, and here they are pictured at their medical technician blouse pinning ceremony. So kids really who had an incredible journey because of their own hard work, because of their family support, and because of this community. So I just want to move on to where we are today. And in our current situation, over the last year, we've been contemplating this partnership and the impact that we've been having in partnership. And in talking with our partners, we hit on a really interesting idea that takes advantage of an opportunity that was really just staring us in the face. And that is, we realized that we could come together as a coalition of organizations rather than working on a one-to-one basis. And we understood pretty quickly that if we did that, there would be some pretty exciting benefits. First of all, instead of one or two organizations advocating for funding for a particular uh, need, we'd be able to come together as 6 organizations advocating for those needs, for these urgent resources to prevent this needless death and suffering. And with those additional resources, we could reach even more children to scale and impact than we had previously been able to. Thirdly, as we implemented these programs as a coalition, we'd have the opportunity to really share our experiences, our successes, our failures, and our innovations, and really learn from each other, which is a really important piece. And then finally, together, we could increase the odds of sustaining these efforts by conducting joint research across multiple countries and research and regions and sharing that research with national health policymakers, funders, so forth and so on. So, drum roll, please. I'm excited to say that over the summer, we launched a coalition we are calling Child Thrive. And the aim of this coalition is to prevent deaths and suffering from completely treatable, preventable often health conditions, and to support kids' journeys out of poverty through education and career readiness. To round out the coalition, I mentioned the partners prior, but we also invited the Children's Place Chicago team to join to share their experiences and likewise learn from their international colleagues. Finally, we invited research aid networks to join us to help with coalition-wide research activities. This is an organization that specializes in research at the community level to benefit the community, not just research for research's sake. So I'm truly excited that as of today, looking across the coalition, even just getting out of the gates for a few months, we are currently reaching over 7,000 kids. And all of that is possible because of our coalition partners and because of all of you. We're really looking forward on building on that number over the coming months and years. And so this is really just the beginning. So I'm going to close and we're going to get to kind of the meat of our program today, which is to hear directly from our partners. But before I do that, I want to share one more story, and this is out of the Dominican Republic. And so hopefully you see this photo of Anna. And the story of Anna is someone who arrived at our partner Clínica de Familia in the Dominican Republic in La Romana, a provincial town. And when she arrived, she was in the arms of her grandmother. She was only 18 months old, and she was HIV positive. Her mom had basically chosen not to acknowledge her HIV status and did not want to pursue care. And unfortunately, this is an altogether too common situation where the stigma around certain conditions, whether it's HIV/AIDS or epilepsy, is so powerful that sometimes kids don't get access to care just on that basis, never mind medicines or what have you. But through Clinica, she received food, transportation to the clinic for her appointments, medications, medical and psychological care, of course, and regular home visits. And I'm super excited to say that Anna is now a candidate for a Child Thrive University scholarship. And she has so appreciated all of the support on her difficult journey toward adulthood and has asked us to share that. And I just want to say right back to Anna, we thank her for inspiring us, see her journey, her ability to overcome these incredible challenges in her life, and then also inspire us to reach even more Annas. So just close it out by saying that, Child Thrive is really more than just an initiative. And I hope you're getting the sense of that today. This is an effort to reach kids who really need our help and our support. As we continue to work, this is also going to be a commitment to breaking down inequitable barriers we see as kids are trying to access just basic things, basic medications and education that we all may take for granted. So to further share this amazing work of the Child Thrives Coalition, we are honored today to have the newest member of the coalition with us, Dr. Festus Njuguna. I'm going to turn it over to Children's Place International Board Chair Ty Shockley to welcome Dr. Njuguna and to present him with our International Hero Award. Ty?
Yeah, napewa International Hero Award.
Can everybody hear me? Okay. I just heard something. All right, good. Hey, thanks, John. Hey, everybody. It's really great to see all of you on the call today. And it's truly an honor for me to introduce you to a truly remarkable individual who's really dedicated his life to making a profound impact on the lives of children in Kenya, especially those with sickle cell disease. Dr. Festus Njuguna is the head of the Pediatric Hemato-Oncology Unit at Moi Teaching and Referral Hospital in Eldoret, Kenya. Now, you're going to hear a little bit more about sickle cell disease, but let me just tell you a little bit about it. It's a debilitating genetic blood disorder that affects thousands of children in sub-Saharan Africa. Yet access to the specialized care that is required is often limited, and the mortality rate remains heartbreakingly high. Listen to this. 50 to 80% of children with sickle cell disease in Kenya, for example, don't make it to their 5th birthday. It's just an incredible statistic. Now, as you can imagine, the challenges of treating sickle cell disease in this region are immense, and the resources can be very scarce. I would say they are scarce. Nevertheless, Dr. Festus has become a beacon of hope for countless families. He not only provides critical life-saving medical care to these young patients, He's a tireless advocate for raising awareness and improving treatment options in a healthcare system that is really often stretched to its limits. Now, it's for those reasons and more that Children's Place International is very honored and proud to present Dr. Festus with our International Hero Award. Thank you, Dr. Festus, for all you do. Truly admirable and remarkable work. Now, for the record, I want you and those on the call to know that this is an award that comes with a financial grant in support of your team's urgent work. Dr. Festus, congratulations. I know, John, if we want to give a round of applause like this or virtually, but congratulations, Dr. Festus.
I'm definitely clapping. I love it.
Great.
Thank you very much, and I appreciate the award. We've been working over the years, and this award and this recognition is a joint effort from all the people in the team that we work with. And our hope is that we keep working together to improve the situation of the children suffering from sickle cell in Kenya and the rest of sub-Saharan Africa. Thank you very much.
You're welcome. So, John, well, thank you, Dr. Festus. I think now is the time in our program for a short panel discussion where we're going to learn a little bit more about sickle cell disease and its treatment in this part of the world. So I'm going to invite Dr. Festus and another amazing pediatric doctor from the Child Thrive Coalition that John described, Dr. Esther Majaliwa. She's the head of the Pediatric Hematology and Oncology Unit and the coordinator of the Sickle Cell and Hemophilia Care Center at Kilimanjaro Christian Medical Centre in Moshi, Tanzania. Now they're going to tell us a little bit more about sickle cell treatment in their home countries. Now, Catherine, I don't know, is Dr. Shu,
yeah.
Is she, you are, John? Okay. So John will be moderating our panel today, and if Dr. Julia Shu joins us, she will moderate from there. John, go ahead.
Yeah, thanks, Ty. Yeah, we are anticipating that Dr. Julia Chu from the University of Pittsburgh will be joining us, but she is caught up in clinics, which we completely understand, and I know our panelists understand as well. So I'm going to fill in just a little bit, and maybe she'll be able to join us in just a minute. So thank you both again for being here today, and we just thought it was such a great opportunity for bringing this community together and for them to hear directly from you on the situation of sickle cell and how you are experiencing that with your patients, and just to really hear firsthand about things. So just to start off, maybe we could just get a little bit of an intro with both of you and how you are coming into this work. I'm wondering if you could both share a little bit about your journey into medicine and what inspired you to want to treat vulnerable children. So let me ask our Hero Award winner first, just to give a little reflection on how you got into medicine and what inspires you. Dr. Njuguna?
Yes, thank you very much for that. And I think my journey to medicine, from high school was largely driven by what I would call, the performance at that level. And I think it was common in Kenya then that if you got a good grade, then everybody around you said, well, you should try medicine. And I think that's what I did. But as I went through my medical school and then I started working in internship, during internship, I got to work in the pediatric ward, and it was a very enjoyable experience. It was my first unit where I was able to work independently, be able to take night calls, and I found them very fulfilling when I was attending to the children at those late hours. And after that, I think by the time I was finishing with my first year, after finishing medical school, I had made up my mind that I want to pursue pediatrics. Then along the way, when I was now, so in Kenya, once you finish medical school, then you'll become what we call a medical officer. And as I was working in the pediatric ward, I was working in a unit where there were some children who had blood disorders, cancer and sickle cell as well. And during my time there, I found it there was a lot of suffering they were going through, and access to medications was a problem. So even as I went on to do residency, I knew that I needed to come back to these children so that I can try and solve the difficulties and problems that they were going through. So it was more of trying to solve the challenges and problems that I saw that inspired me to take up care for children with cancer and blood disorders.
Wow, thank you. And Dr. Majaliwa, would you share a little bit about your journey into medicine? You're on mute.
There we go. Thanks, John. Yeah, so I think I knew that I wanted to be a doctor since I was young. And I think it had to do with the white coats, something with the white coats that the doctor were wearing. They look so smart and professional. And in my heart, I was saying to myself, like, I want to be important. I want to bring solution into this world when I grow up. But also I had a very supportive family who wanted me to fulfill my dreams. So that was easy to join the medical school. And during my medical school, in the third year of my training, I had a great pediatrician. She was very kind, always smiling, talking about the children as if they are like, angels. And that really inspired me to want to be a pediatrician. But then later on, like my story is like Dr. Festus, during the residency, children with hematological and oncological diseases had a lot of suffering. And by then, our hospital, we didn't have any expertise. So there were a lot of suffering. They were just piled up in a room. There were like very few pediatricians had interest in treating them. And so that led me like deciding that I want to bring hope. I want to relieve the suffering. I want to be a solution for these patients. Yeah.
So I see we have Dr. Chu has joined in, so we can perhaps bring her up, Nicole, too, on the spotlight. And I'll just say, as we're having Dr. Chu get situated here, so Dr. Njuguna and Dr. Majaliwa practice very far from each other. That's actually kind of interesting. I mean, it's far, but not far. So Dr. Njuguna is in Eldoret, Kenya, with Moi Teaching and Referral Hospital, which is, again, as I mentioned in my earlier discussion, both of these organizations are very well known. And that's actually in, like I said, Eldoret, Kenya, which is famous not only for Dr. Njuguna's work, but for our Kenyan world-class marathoners and runners. So you might have heard of Eldoret before. It's a beautiful spot higher up. So the elevation gives something to the runners, I guess. And then Dr. Majaliwa is in Moshi, Tanzania, which is famous in its own right. Some of you might have heard of Mount Kilimanjaro before. So we have Dr. Majaliwa at KCMC, Kilimanjaro Christian Medical Center, also one of the top hospitals in Tanzania. It's a national referral hospital. It's just a little more background on where they're practicing. So, Dr. Chu, thank you so much. I explained that you were on rounds, and I know it's very hectic. I'm glad you could join us. We've just gotten through the first question, so perhaps you could take it from here and ask a little bit about the sickle cell and the situation concerning kids and outcomes, and take it from there.
Perfect. Thank you so much. I really apologize for my clinic running over, but really nice to meet everyone. So glad to be here with you all today, and really a pleasure meeting hopefully future colleagues. And I'm really looking forward to this conversation. And so, like John said, I think it would be wonderful to hear more about what the situation is like in each of your respective institutions. What are the resources that are currently available for children with sickle cell disease? What is the care like for them? there, the clinical environment, and what do you experience clinically on a day-to-day basis taking care of these children? I don't know who spoke last. I don't know if Dr. Esther, Dr. Festus want to give an answer.
Festus will go first.
Okay, thank you, Esther. And so our hospital is located in an area close to area that is endemic with sickle cell, so to speak, because it is near malaria endemic region. And we, as a country, estimate that there are about 14,000 children born with sickle cell annually. So a lot of these do not get a diagnosis during their neonatal life or even during infancy. So it means that most of the diagnoses that happen in our situation is when patients are sick, they come to the hospital and they have another illness, and then from the clinical evaluation, then one may suspect that they may have sickle cell disease, and that is how majority of them get diagnosed. And then once they have a diagnosis, of course, they need the care that is supposed to be provided in the clinics. And, like the main medications, hydroxyurea, penicillin, and, the specialized immunizations that they need to do. So you find there's a challenge in terms of access, mainly for hydroxyurea, just because of the cost of the medication. Although this has improved in the past few years, still we have a considerable population that is not accessing this medication. When we think about 10 up to maybe 5 or 4 years ago, that was a big challenge, but I think through efforts from various partners and also from our government, now there is some access to these medications, not at the level where I would want it to be, but there is an improvement in that area. And then the other things that we need to think about is a lot of children, if you take good care of them, then transition into adolescence and finally to adults. And those are areas that are also having deficiencies in terms of how they can move from being seen in the pediatric clinic and going into the adult clinics. But by and large, we've had improvements over the years, and we hope we can continue working together to make it better.
Yeah, so although we're far from Eldoret, but it seems like our situation is similar. So unlike Eldoret, Moshi is not endemic. Well, we don't have high prevalence for sickle cell disease, but we are a national referral, among one of the national referral hospital, which we do get patients from other sites, other regions which have high prevalence of sickle cell diseases. As we know that it is a genetic blood disorder, so there are areas which are hotspots in Tanzania. So there are some regions which have high prevalence of sickle cell. So yes, a big problem in early diagnosis. Currently, we do not have neonatal screening in the country. So majority of the patients that we receive present with complication, and hence a big number of them end up having morbidity. So that is one of the challenge. Festus talked about follow-up strategies, which is also among of the problem that we are seeing. We get patients, we diagnose them, but then once we send them back, there's really no follow-up, and hence these patients are lost to follow, or then they turn up to us with severe complications. Yeah.
That's very interesting that like you said, even though the two regions are so far apart, the challenges that you face as providers and on a national level is very similar. Right? And I think that's probably similar for, fortunately, a lot of the world where sickle cell is prevalent, a lack of newborn screening, late presentation to to care, inability to prevent some of the early childhood mortality that we potentially could with getting them in after birth and with penicillin, vaccines, etc. So it's really unfortunate. One thing that I did want to ask a little more about is access to hydroxyurea. I know this has been a major challenge and certainly a major advancement in a lot of countries. But where do you think your country is in terms of adoption of hydroxyurea? Like what percentage of patients do you think are actually getting treated at this point? And how close are you, or are there advocates at the national level pushing to get hydroxyurea included as part of the national formulary, for example, or other strategies to fund hydroxyurea access moving forward?
So I can start answering that question. Yes, so availability or access to hydroxyurea is a big challenge in Tanzania. Although we do have a national sickle cell guideline, which recommend all patients to be diagnosed with sickle cell to be on hydroxyurea. But again, the availability is very limited. And one tab of hydroxyurea costs something like 25 cents. And that is significant amount of money in our setting. And imagine that patients need to take this every day for the rest of their lives. There are some, like, you can get it through the health insurance, but our statistics shows that I think even less than 20% of our population are insured. So most of our patients have to pay it from their pocket. So hydroxyurea availability is a big challenge in Tanzania.
Yeah, so just to add to that, is that we suffer some bit of those challenges. But as I had said earlier, we have seen some improvement in the last few years. And the government has published the national guidelines for treatment. The medication is on the essential medicines list. The government procurement agency for medicines stocks the medication. And we are having more other private distributors that are able to provide the medication. And I think through some of the partnerships with the pharmaceutical companies, the price is much better now than it was in the past. May still be a challenge to some of the patients, but I think we have tried to work out some mechanisms, especially in the clinics where we are working, to see that cost is lowered completely. So, for example, like the clinic that we run in Eldoret, anybody who requires to have a hydroxyurea, and that is for people with sickle cell disease, are able to get it. For the very poor, then we are able to work out mechanisms in which they can access it. But this is not the case in the rest of the country. But I think now we have a strong advocacy body. Even in the country, we have a national parents body called the Sickle Cell Federation of Kenya. And I think through that effort in the past, like 1 year, they've started talking with the government, but we hope this will bear fruits so that it becomes more available. And I think our national health insurance body has proposed a package for people living with sickle cell disease just to try and enhance the care. So we hope these are things that can keep leading to improvements in the care and access to hydroxyurea.
That's wonderful. That sounds extremely promising. It sounds like real progress has been made with such vital access to care. And certainly with more treatments coming out, the more we're able to get patients into care and get them established and stabilized on hydroxyurea, the more you can think about additional, more advanced therapies as well. I'm curious to know, Dr. Esther and Dr. Festus, is there any access to other approved sickle cell drugs like voxelotor, crizanlizumab? So, recently, for anyone in the audience who doesn't know, we've had an explosion of drugs being approved by the FDA for sickle cell. And I say explosion, there's been 3 relative to 0 for the past few decades. But it's incredible. And, it's really, it's been so revolutionary and given so many patients hope to have not only drug therapies, but now gene therapies available to sickle cell patients. But one of the things that I think the entire sickle cell community struggles with is, how do you get these treatments to the areas of the world that most need them? So Dr. Esther, Dr. Festus, what do you think about that?
So I think all these new therapies are not readily accessible to patients. I think a few of the patients in our population were included in the clinical trials for some of the medication. But I think that is as far as it went. After the trials were over, and then they could not have access to medications. But I think by and large, we need to have maybe what we call access programs. And I think that has worked with some of other diseases and other newer molecules, where there's a price differentiation for the low middle income countries as compared to the high income countries. But even as we do that, I think it is still important to keep emphasizing on the availability and access of the medications that have been there for a long time, which are cheaper and have also been proven to be effective, even as we wait for the new molecules to become available.
Yeah, so situation is the same as in Eldorate. Crinolizumab, we're just going to be part of the trial in Tanzania. So these are new medication. But again, the question is availability after the trials. That's usually one of the biggest dilemma, which our settings like ours face after clinical trials. But then in regard to specific treatment for sickle cell patients, we do, 2 years ago, we had started, not my center, another center in Tanzania had started transplanting patients with sickle cell who basically under 6 years with a SIB match because of the good outcome. So it's a program that has been started by the government, but of course, still the price of doing a transplant, it's super expensive, and the whole thing need to be covered by the government. And also, so it's a program that it's starting, but then there is a question of its sustainability, because the patient, an ordinary citizen, will not be able to afford that.
Yeah, no, that makes sense. And a really challenging issue to address, because it, in addition to the monetization, how much these drugs cost, there's that question of infrastructure and availability of resources, of treating a select few patients with a very expensive treatment versus being able to provide more universal access to hydroxyurea, for instance, right? There's always that trade-off when you're in a low resource area. But wonderful. Thank you for sharing that. One question we have in the chat is, what do you think about stigma and potential other perceptions of sickle cell that may influence care in the clinic and perhaps outside as well?
Thank you for asking that question. Actually, it was among one of the challenges that I face in treating patients with sickle cell in my community. So huge stigma. associated obviously with a poor knowledge in the community, and you wonder that we are among of the high prevalent country with sickle cell disease. So you would expect that people to be aware, but we see that as a challenge. The community has very little knowledge about this disease, and some of them associate it with witchcraft as usual, bad luck, and things like that. And oftentimes when things are associated with belief, it's really hard to look for, appropriate treatment, to look for care. So yeah, stigma is a big issue, and I think the only way that we can solve it is just advocacy, and yeah, increasing knowledge in the community.
To follow up on that, I'm curious to know if you've had any experiences with either local or international partners working on advocacy or education, to help improve stigma care, education, and what you've found to be successful in that type of international partnership.
Yeah, so for us, I think we've had some experience with the international collaborations because the institution we work for is also part of a collaboration called AMPAP, which is a collaboration that is between our hospital and teaching university and some universities in North America. So we've been privileged to work with a group from Indiana, called Indiana Hemophilia and Thrombosis Center, in terms of providing education mainly to healthcare workers, but also to patients and families. And I think that has helped to create a bigger workforce that can help with caring for children and adults with cancer. But it has also helped us be able to create patient education sessions, patient education materials, so that we can also deal with the problem of stigma and making patients more aware of how they can access care. And I think we've also had another partnership that we are working on together with the Ministry of Health that is also enabling us to increase the workforce for caring for people with sickle cell disease, and also to provide the same education to what we call the community health volunteers or the community health promoters, people who really work at the primary level in terms of identifying people with sickle cell disease and ensuring they adhere to their care. And I think some of the changes that we have also seen in the government level probably have been informed by the work that we have done in collaboration with these partners. And we've been able to go for several meetings, several advocacy sessions with some of the partners. And I think that has really created an impact in the government and led to some of the improvements that we have seen in the past few years.
Yeah, so I actually believe international collaboration is crucial, is instrumental in bridging the care gap in low and middle income country, because you guys have been there, so it's easy to advise based on the settings that you already are, or the experience that and the skills that you the collaborators already have. So it's really important, and I think it brings a lot of growth, and it brings a lot of positive income into the positive output into the community. One of the example, not specific to sickle cell or stigma, is our collaboration with CPI, our current collaboration with CPI with our oncology patients. So through CPI, they have helped us with resources in providing education nutritional support, family support for cancer patients at KCMC. And through this effort, we find ourselves that now we are able to give comprehensive cancer services to our children coming with malignancy. So yet again, a strong believer of international collaboration, and I believe that it always most of the time brings a very positive impact.
That's wonderful. And I definitely want to hear both of your visions about, what you hope sickle cell care looks like for your institution and countries. But before we get to that, there's an interesting question in the chat that I just wanted to point out. The question is, could you describe the life of an average sickle cell patient in your area? I think that might be very enlightening for all of us.
Yeah, so as we had mentioned before, so most of people with sickle cell disease will get diagnosed because they've attended a health facility, they've been admitted for another disease, and then at that point, then you have to sort of start educating the family and making sure then they come for clinic after that. And usually one of the challenges is then once they go back home, now they have to explain to the rest of the family about the diagnosis. And that can be a point where, the misconception about the disease can make them either come back to the clinic or not, because some family members may feel this is really not true. And that can also create some frictions within some families, especially when they don't understand how the disease is acquired. So I think those are some of the scenarios that we see. And then when now they have to come to the clinic, I think it has been that, they have to travel quite some distance to be able to access care and also to be able to get the medication that they require. So travel distances, thinking about issues of health insurance, those have been a big challenge. And then when now they start going to school, now that becomes a bigger challenge. The teachers understanding about the disease, while the child needs to go to the hospital often, that becomes a reason for them to be isolated, because maybe the teacher will feel, why is this child requiring to go to hospital many times? And then that, of course, affects their school performance. Then they can proceed very well with the academic work, and then that even lowers their chances of getting economic empowerment in the future. So those are sort of some of the challenges that I would say they encounter in their journey. The high cost of the medication and the hospitalization, and in the absence of insurance, then that really drains the families and leaves them in a very vulnerable position, especially economically.
So basically, in my setting, actually, it depends on where you're born or where your parents are living. So if you're in the city, then access to care, hydroxyurea and all these things will be available to you. But then the big issue is those patients who are in the rural area. Our statistics shows that majority of them do not reach their 5th birthday, and John had mentioned this during the introduction. And these are the kids who are in the villages, whereby the doctors have very low-level suspicion about the disease. They do not have tools to diagnose the disease. And then once they're referred, they present to us with complications, so end up with morbidity, or they die. So the picture is different, depends again where are you located. Yeah.
To follow up on that, the children and their families face so many barriers and challenges, even to get through the early phase of life. By the time you start seeing them and they become adolescents, do they have hope for the future? I mean, what do your patients look forward to? Do they, what kind of life do they picture for themselves, beyond childhood struggling with sickle cell disease?
I think it has been that majority of the families, and I think this goes on with the children, is that they believe the children will not live beyond their teenage. And many times when you speak to families, they have and communities, there's that perception. In fact, sometimes when you introduce a person with sickle cell disease who is in their 20s or 30s, people really get surprised. Although I can say now we have a few more who have reached that age. But it has been that most of the families would be feeling like, beyond teenage, our child will not be able to survive.
Yeah, in my center, it's usually the question is, will the disease go away? Will I be cured in this lifetime? And oftentimes the answer is, no, you'll not be cured, but we'll try and make your life better. Pain is always an issue. So pain control usually is one of the things that we really strive to just reduce suffering to these children.
Sorry, automatic lights in the clinic room. While I fix that, another question in the chat: are there community group support programs that have been successful for families, and what made them successful?
So we have support groups that have been initiated either by parents or by people living with sickle cell disease. And we have quite a number that have been successful in bringing these communities together, advocating for their cause, and being able even to, I know there's some which are even trying to do economic empowerment for the families. So I think when you have a strong either parent or person with sickle cell disease who believes that they can make a difference, and they work with the community around them and with the medical community and other sectors, I think they can have some success. And we've seen them play a great role in influencing some of the government actions and policies.
If I may follow up with another question in the chat, Dr. Esther, you had mentioned pain control, and this was actually a question that was on my mind as well. So thank you for asking it. The chat says, do you have adequate access to pain meds like morphine?
Yes. So the answer is yes, we do, but not in a continuous manner, I can say. Oftentimes we have oral morphine, which is easily available, but IV morphine is a challenge.
Thank you. Oh, sorry, go ahead, Dr. Festus.
No, I just wanted to say, yeah, morphine is available, especially the oral formulation is quite accessible.
Great. And I think we need to wrap up our conversation. Do we have maybe time for just a quick answer from each of our panelists? I would just love to hear your vision for maybe the next 5, 10 years. What do you want sickle cell care to look like in your country?
So I'll start because Festus is already doing a good job. So I have a big dream to achieve. So my dream is for my patient to reach adulthood, because we have very few adolescents and young adults, in our settings because lost to follow-up, they die. So I want to see that. I also want to have a
Oh, Dr. Esther, can you still hear us? I think your video might have frozen. Oh, we may have to have Dr. Esther come back and continue her answer. Dr. Festus, do you want to step in real quick, give your answer?
Yeah, I think what I would really wish to see is our country adopting a newborn screening strategy, and then having a health insurance cover that takes care of people with sickle cell disease, and having increased access to hydroxyurea. I think if we could get those three things in place, our people living with sickle cell disease will have much better lives.
Absolutely. Those are, what sound like simple things to list, but extremely hard policies to implement. So those are still huge dreams. And Dr. Esther is back, so let her finish up.
I don't know what you didn't hear, but I just said the big dream is to improve overall survival of patients with sickle cell.
Thank you so much. Again, something that I think the entire community is hopeful for, especially as more and more energy is being put into sickle cell disease, both treating and curing the disease, and hopefully as we all continue working together to try to really improve care across countries and care environments. Hopefully that dream will become a reality in the near future.
Thank you.
Thank you so much.
Just want to really thank our two panelists, Dr. Njuguna and Dr. Majaliwa, and of course our moderator, Dr. Chu, for a really insightful and very sobering, conversation about the situation that kids are confronting in East Africa relative to sickle cell disease. It's really through your compassion, your expertise, and your unwavering commitment to your patients, Dr. Festus and Dr. Esther, that you have transformed the outlook for children who face incredible odds, and no doubt have improved the situation enormously over what would have been the case. So it's really truly inspiring to hear firsthand your experience, and for you to share that with the larger Children's Place International community. So thank you so much for being here, and thank you for staying up late. So I'll just wrap up by saying the work that you heard about today, this is truly what fuels the Place the Hope campaign. And so the campaign brings direct support for the most urgent needs that children have, and brings hope for that future that we all want to see for these kids. So if you felt at all inspired, hopefully, to get involved, we're going to put a link into the chat and for the Place the Hope campaign that you can click on, or you can reach out to any of us at Children's Place International to learn about how to get involved. As previously mentioned, the campaign goes until the end of the calendar year, and the support goes to our Child Thrive partners and families. So all of the things you heard about today, plus other partners, will benefit from this campaign. So we're going to be sharing more about the campaign in the coming weeks and months, and we hope you'll join our Child Thrive Coalition. And as a final note, we're going to be hosting an end of campaign holiday party on Thursday, December 5th at 5:30 p.m. at Artifact Events in Chicago. Invites will be coming out later this fall, and we hope you can join us. So again, a heartfelt thanks to all of you for being here today. Our Child Thrive community is a true testament to the power of solidarity and the difference that we can all make in the world. This work and your involvement truly matter. So thank you again, and take care, everybody.
Thanks.